All right, good morning, everyone. Thank you, Nuvolo. So we're going to start off with a quiz. If you noticed in your pamphlet, I am definitely not Roderick Williams. So for those of you though that know Roderick, he's somebody that you definitely should get to know. Great guy to work with. Funny story. I began working in IDNs under Roderick with CHC. Then about a decade down the road, he worked for me for Advent Health, and now we're here today. The good news for Roderick, he's not here because he accepted a CEO position for a small community hospital in Alabama. Unfortunately, he's a Tide fan and big Alabama supporter, so I'm not going to hold that against him, but I'm very happy for his success and was happy to step in. Although very last minute, called me Friday morning, said, Damion, my signing for my new job is coming up on Tuesday morning and I need a pinch hitter. So since I'm located right down the road with CHC, here I am. So hopefully I can get through this for you, touch on a couple things. I'm not going to get too deep in the weeds. It's going to be pretty high level, maybe some obvious stuff. Been to many of these MD Expos, always full of great information. All you sitting in the audience are subject matter experts already for the fact that you're here. You're part of HGM, you love it, you live it. You get to enjoy all the fun adventures that come every day with the job. So just wanted to really touch on a few things that will keep in the back of your mind to maybe make the Joint Commission, DNV, CHIQ, CMS process just a little simpler for you. So my name's Damion Schinnerer, very close. I know it's not the easiest name to pronounce. So like I said, I work with CHC. We support small community hospitals. We have about 170 across the country. I support them with purchase services, capital service contracts. So I'm still part of that biomed space where we really try to focus on producing the best quality for our facilities, especially since a lot of these are small community hospitals located in the middle of nowhere. That's kind of near and dear to my heart because I grew up in the middle of nowhere, Kansas. Literally came from a town that had twice as many cows as it did people. So now I live here in the big city of Plano and get to be here to present to you today. So like I said with the agenda, gonna not really like dig into the weeds of the regulations or the minutia of the various criterias, but just things to keep in mind that a lot of times perception is reality. Many organizations, you know, they focus a lot on crossing the I's and dotting the T's. I said that completely backwards. Dotting the I's and crossing the T's, which by no means is this presentation meant to change that. But sometimes it's the surface level things that we really miss out on. Some of the times when you walk into a room, and I've been through well over 100 different surveys, and 9 times out of 10, they walk in, if everything looks good, they move on. If the surveyor walks in and sees something out of place, he walks up, he looks at it, then he looks at the next one to see what's different. The third one is one of these things is not like another. Was that Sesame Street, I think? Some of you guys are old enough for Sesame Street, some of you maybe not. But it's really look good, feel good. If the equipment looks good, they trust that it works well. If things are dress right dress, Veterans Day, thank you to all the veterans, by the way. The assumption is everything's good to go. Out of those over 100 inspections, probably less than 20 I've had to crack a book. So a lot of it is just making things perceived to be in good working order and that we keep our ducks in a row. I keep this presentation super simple. I'm not super wordy. Well, I might be wordy, but I don't like to type a lot of words. So, you know, a lot of the instructions for what we need to do to prepare for our surveys are out there, whether it's in your own organization's medical equipment management plan, OEM's manuals, IFUs, CMS. There's a ton of great information out there. And the reason why I kind of, use the two pictures is about 30, 40 years ago, you actually had to read a book. It was kind of difficult. You had to make sure you had the right version and that you were up to date, making sure that your ECs were correct when you put them in your medical equipment management plan. But today, it's a little bit more streamlined. We kind of have that satellite GPS that can take you right there with the amazing Google searches that are available. There are also other opportunities to streamline the instructions, so forth, for your techs. Something as easy as utilizing Nivolo to create checklists to make sure that your technicians, all the work orders look the same. One of the big hurdles that I faced when auditing work orders for inspections were the fact that Tech A may write a short, I was going to say soliloquy, but I'm not going to go down that path, a short novel when explaining the fact that he checked the operational function of that device. Tech 2 might say functions per manufacturer's recommendations, and Tech 3 goes somewhere in between. So the question is, which one of them is right? Which one will the inspector prefer? It's hard to know. But with standardized checklists, CAN nomenclatures, you can really help streamline some of that process. Obviously, if they go through, read the procedures as set forth by the OEM, by your medical equipment management plan, maybe your AEM plan, you just streamline that process. You make it easy, you make everybody have the exact same orientation. Plus, when you're auditing, you print that out, you look side by side, and it's pretty easy to spot what's dissimilar. It also helps streamline your process when trying to conduct that actual work, either PM or corrective action, because how many of us have had a tech come back to get the manual, then go back out, then come back and get the tool that the manual referenced, then go back out? Ideally, by having checklists, utilizing Nivolo, which we'll keep mentioning throughout this presentation, it should identify and outline all the needed devices necessary to go out and do that work, whether you're scanning them in for regulatory compliance to backtrack that calibration, or if you're just trying to standardize what is being done and what is being captured in the work orders. Paperwork. We all love paperwork. Once again, our partners in Nivolo can help streamline that, as well as all your CMMS systems. Out of curiosity, does anybody still use paper today? Okay, I believe it. I believe it. It's not too long, and working with small community hospitals at CHC, all PMs are still in a binder at some of these small facilities because they don't have a CMMS system. However, what you want to do to be prepared is make sure your reports are ran, they're up to date, which all of you guys know this, but ultimately have it in an easy, digestible format where you can reference it quickly. So many organizations are very guilty that when an inspector asks for a piece of material, that they'll run back to the shop, spend about 2 hours getting that piece of information, come back, and then generally over deliver that information. The guy may just ask, when's the last PM? But they provide the whole service history, which may be turning themselves in on a potential issue because they've just given way too much information. By being prepared, whether it's in your books showing your EOC compliance, showing your recalls, showing your notifications, you're able to turn to that page, hand it to them directly. That's really what they want to see. Or sitting there in front of them with your laptop, tablet, hey, can I see the last PM? Here it is. It's that instantaneous response that generally gets them to move on to the next topic. Hopefully, next department, kind of in that chain. So avoid the chaos. That chaos is going to create additional time, the more questions, the more opportunities for that inspector to go down that rabbit hole. So kind of avoid the Alice in Wonderland effect, keep them out of that rabbit hole, make it easy, make it simple. So as biomed and IT kind of cross paths, this is a sticking point that I've seen many organizations get tripped up in. And this is just a good picture to kind of represent that. How many of us have installed new patient monitors and we need a 3-foot cord, but they give you a 12-foot cord, so then you double it over and over and over, and then you zip tie it. And then when you go to repair it, you cut the zip ties, you undo it, and then the cable management just kind of falls apart. So the big idea here is if it looks right, it works right. If it works right, they move on. So spending the extra $2 on the appropriate size cable save you a whole heck of a hassle. Or in retrospect, it goes the other ways. How many of us have had a monitor that has a extending arm and the nurse pulls it too far, then it unplugs it and the nurse says, oh, it won't power on. We all ask, is it plugged in? And they say, of course. You go up and you plug it in, they ask you what you did, and you got to say, oh, I had to reboot it, or you have to say something nice because it's not just the piece of equipment you have to fix. You have to fix their confidence in that device as well. So additionally, as the IT portion, the network portion, the access point portion grows, more and more inspectors are getting into making sure that these devices, switches, routers, servers, UPSs are also in the equipment inventory. Many organizations will have a failure. They'll identify the failure, but it will be an IT related issue. But then there's no asset to connect that issue to. What was actually fixed? What was replaced? That is a little bit more so with liability. That's more so with recalls and issue, what do I want to call it? Patient incidents that you're going to run down, but many times if those IT components are not identified, labeled, inventoried, it's a dead end, which leaves you to be a sitting duck when it comes to a potential litigation. So partnering with your IT department, having different colors of cables to identify what's medical equipment, what's IT equipment would be a major recommendation, so that you know what's yours and what's theirs, and hopefully they don't get too confused. So this one is a great representation because you'll even see the fibers in yellow. Wouldn't get too particular about them doing different colors of fiber pulls, but the cabling is a nice little touch. So I'm a big Chiefs fan, which the funny part here is you guys will probably notice something, that my good picture is from a game that Kansas City got blown out in the Super Bowl. So don't mind that, just proper alignment, consistency. Here we gotta love this guy, Kadarius Toney, might have cost us that game, being lined up off sides. So it's that inconsistency. When the inspector walks into the room, sees all your patient monitors, dress right dress. They have the asset ID in the upper left-hand corner, the PM sticker in the right-hand corner. All the PM stickers are the same color. The cable management looks good. They're gonna move on. Now, they walk in, they see one where it's all kind of funky and something's going on, cables are dangling from it. Maybe the PM sticker's missing, the asset tag's missing. That's going to draw them in. That's going to get them to look at that device, probably ask some questions, cause them to go down that rabbit hole. So by just keeping it consistent, by standardizing label placement. Perfect example, many times the side of the monitor may be showing to the door. Obviously, a lot of organizations will say upper right-hand corner, but it doesn't make it easy to see because you got to go into the room. So by putting it door facing, maybe in your policy, your procedures might simplify that a bit. Same thing with beds and stretchers. A lot of organizations put those tiny little PM stickers under the footboard where you have to go in, disrupt the patient. Recommend maybe getting the bigger stickers, putting them on the lower frame on both sides potentially. So it's easy to identify rather than having to continuously ask your clinicians to assist you. You make it easy. You make it simple. It's kind of hard for them to say, no, I don't know what's due for PM when there's a label that's this big on both sides of the bed and it's green or yellow or pink. So that's another key point is you just got to keep it simple, make it easy to create accountability. So although the Chiefs did everything right, sometimes things don't turn out the way you want them to, but hopefully things will turn out better this year. All right, number one pet peeve. Now, don't get me wrong, both beautiful cars. However, a Ferrari is just naturally an amazing piece of art. So the thing that always gets me, always, is you'll walk in, we'll look at a patient monitor, a ventilator, a defibrillator. There'll be a capital asset tag from accounting. There'll be a equipment tag from the hospital. There'll be another equipment tag from the third-party biomed vendor. There'll be a filter tag. There'll be a battery tag. There'll be a software update tag. There'll be, nobody knows what to look at. It begins to look like a NASCAR. I didn't find a good NASCAR and didn't want to call anybody out in NASCAR if you're a fan. I know we're in the South, so I wanted to be careful. That's why I use this Ferrari. So it's streamlining, it's making it simple. In the digital age, we should be able to scan that barcode, pull up all the information necessary, know when the filter was changed, the battery was changed, if the software update's been done. In the middle of a project, I completely understand maybe putting a dot on it that, yes, we've touched this one. But eliminating confusion, once again, referring back to the clinicians that you partner with, you want to keep it simple. You want to make it easy. You want them to know, hey, they walk in, they check the asset and the PM label, we know it's good to go. Hey, 2025 is green, 2024 was yellow. All right, if it's yellow, we need to see it so you can communicate that, you make it easy. Many organizations expect clinicians to actually get and read that small little tiny script on a sticker that may be on the back, on the front, on the top, on the bottom. It's very hard to get them to play ball and to hold them accountable if we don't make it simple for them to do so. So by streamlining the labels, hopefully you get to maintain the beauty of that device and also create a little bit of accountability when it comes to the partnership between HTM and the clinicians. So when you take all those stickers off, what happens? And I know it's not just biomed or HTM that does this. The clinicians are just as bad at putting various tapes and labels and goo and stickiness. So the perfect group here to take this hit is actually infection control. I've fought this time and time again, trying to get the clinicians to stop putting tape, especially on the EKGs, the mobile EKGs, ECGs. They love to stick. All right, doesn't like me over there, so I'm gonna move back over here. They love to stick the little labels all over it. But I've also seen HTM be very guilty of this, whether you're replacing the asset number. You don't clean up the previous asset number. You're replacing the PM. I've seen PM stickers literally stacked probably an inch thick. So these are all things that we just want to keep in mind. You know, that's going to create a visual identifier to be like, hey, let me drill down into this. And it's not just the equipment. The cables are the exact same way. Something we're going to touch on in a little bit is the cleaning, because even inappropriately cleaning, excuse me, can create issues of their own. But the other part of this is how many of us use the metal razor blade scrapers? They work great, don't they? But they also gouge the heck out of that equipment, which creates their own issues. How many of us use those nice plastic ones? There we go, there we go. They work great, but you got to replace them on a pretty regular basis so you can maintain that sharpness. The good news is, for the most part, most organizations have gone away from those metal tags that are impossible to get off. You got to soak them in acetone for 3 days in order to, finally scrape them. And most of them gone to a little bit easier tag to remove. But ultimately, if you're putting your mother, father, sister, brother, cousins, aunts, nephews, niece on a device that leaves your shop after PM or after repair, it's a clear decision on which one you want. Yeah, and when a inspector or clinician make their rounds, they know which one they're going to trust. But once again, this is a very difficult fight. So make friends, take donuts to your infection control director, and get her to jump on that grenade for you, because there's plenty of other opportunities for confrontations within an organization for accountability. Let them own this one. Even have them take some swabs, some samples, and I guarantee they'll come back positive. So that's one that it's a real risk, and it's really something to consider. Here we are, proper cleaning. So one of my favorite stories is during COVID. For some reason, clinicians and housekeeping, EVS, decided that IFUs don't matter anymore. They're just going to use whatever they feel like using to clean the devices. We had a facility that had a brand new, beautiful Olympus endoscope suite. We're talking probably $500,000 between the bed, the video stand, the monitors, the booms, the anesthesia cart. Somebody had the great idea of, we're going to use hydrogen peroxide to clean all this. So in about 6 months, every single piece of equipment had corrosion and damage. They wanted me to make a warranty claim, but they didn't follow the IFU. So it was our responsibility to try to rectify that. And actually, one of the guys I called is here in the audience today. Josh with CEMC did a great job of helping us get that corrosion and damage off many of our stainless steel devices. So there are solutions to hopefully overcome that, but it's very important whenever a new device comes in. I always personally delivered the IFU. I met with the EVS manager to say, hey, this is what's appropriate. We even went as far as, and I said no stickers or minimize stickers, but we went as far as identifying, say, a purple top, a green top, a red top. We put a red dot in the dwell time of, let's say, 3 minutes, 5 minutes in that sticker. So a clinician could never say they didn't know what the dwell time was or what color top they should use to clean that. So there's give and take on the stickers a little bit. But what we saw is we quit seeing the corrosion. We quit seeing the fogginess on a lot of our monitors, because most of those you're supposed to wipe clean after the 12th time. How many have actually seen a clinician wipe clean? All right. But additionally, it's an important factor that even in OR, I've seen scrub techs literally dump buckets of water on OR tables. So it's really a proactive approach. It'll prevent time, it'll prevent issues. And even some of the newer devices. I used to be an engineer with Intuitive Surgical, and they had little sensors all over it. If there was fluid intrusion, it would lock it up instantly. So that is starting to become a more and more common occurrence, especially in OR surgery equipment. So proactively taking that on, partnering with EVS, once again, another very difficult one. Sometimes EVS may not be there very frequently. You never know who you're going to be working with. There may be language barriers, but try to make it as simple as possible. In the organization that I referenced with the round color stickers and the numbers, that was the case. Most of them didn't speak English. So how could we communicate effectively and create a layer of accountability to then hopefully help them help themselves and ourselves as well. Hey, it's Smokey the Bear. Once again, if you're not old enough to remember Sesame Street, you may not remember Smokey the Bear, but I hear he's making a comeback. So biomed, about half of us are adrenaline junkies. We love to go put out fires. Many times HTM, biomed, clinical engineers are just waiting for that next dumpster fire to pop up. We get the call, we run, we address it, we get that hero high. So don't get me wrong, no matter how much Smokey the Bear you have in you, there'll always be those opportunities for the unexpected to pop up that you'll have to address, you'll have to overcome, and you'll have to work with your organization to try to resolve. But the biggest issue here is always having that hero, that firefighting complex is a very reactive approach. Many years ago, back when we were with paper and they're picking up phones and they're putting sticky notes on equipment to let us know that it's broken, that may have been the best we could do. But today, with CMMSs such as Nivolo, you can proactively take that approach to see, hey, what's the anticipated failure rate? Is there a recall on it? Is there issues? Obviously, most of us probably travel, all right, I'm not gonna say most of us. How many of us travel with a tablet or a laptop now to do our PMs and work? So you have equipment and information available at a touch of a button. So by taking that proactive approach, you can then knock out the recall, the PM, the corrective issue all in one time. Many times I've had technicians in the past, way back in the 1900s. Some of you caught that. All right, where they'd go do a corrective maintenance just to come down and find out there was a PM on the device. That's the danger of sticking with paper and not moving up with the newer technology, is you can't, kill as many birds with a stone. That's not nice, but you get the gist. So by transitioning to Smokey the Bear and away from the firefighter mentality, you're able to get that proactiveness out there. Smokey the Bear's rounding. You're able to talk with the clinicians. You're able to find out what the issues are before they pop up in emergent situations. Not all of us love that Friday afternoon call. Hey, my CT's down and it's been down since 8 a.m. Well, why didn't anybody call me before then? That's a valid question. However, why didn't anybody round and see how everything's going? Why, that open communication, that proactiveness, what Smokey Bear would be proud of. Communication styles. This kind of goes back to making Smokey the Bear proud. When I was setting this up, I had this picture and somebody asked me, what is that? We know what that is, right? Okay, we got silos. So that must have just been a city person. So we'll disregard that then. But as you'll notice that these silos are not connected. They work alone, they facilitate growing trees, I guess. Maybe they used to facilitate holding grain. So they're great at what they do, but they don't work together. Obviously having a collaborative environment, kind of what I spoke to a little bit earlier in regards to keeping your PM labels, your asset tags simple, you can create that accountability. You can work in a collaborative effort in a partnership to make sure that you're putting and getting all the proper equipment to the necessary places. When we start having issues with this, it creates things like hoarding. We'll see clinicians, oh, I gotta have this. We don't have a proper system in place to get SCDs back here once we send them to surgery. Well, if you're working, you're collaborating, you're able to rectify that situation to then reduce or minimize at least the trickle down effect later down. So with this, and we'll touch on it in another slide here, it's simplicity, it's open communication, it's Smokey the Bear rounding to make sure that he's preventing forest fires rather than running out to take the forest fires. One thing that HTM has really evolved into is you're not just taking care of the equipment. back in the 1900s, it was primarily taking care of the equipment and the paperwork. Now it's about taking care of the clinician and their interpersonal relationship and the trust that they have in that device. If you have an ugly, gnarly piece of equipment, guess what? Anything happens, they're going to assume it failed. If you have a really nice, sleek, clean looking device, they're more likely to troubleshoot it. Oh yeah, it's plugged in, or oh yeah, let me reboot it, or oh yeah, maybe let's try these different lead cables before we automatically assume it's the device that's failing us. So by creating a collaborative effort, you create an environment where you're less likely to see weird equipment come out of the woodwork when the inspectors are there. How many of us have been doing rounds once the inspector gets there and be like, where'd that come from? I've never seen that before. Or that thermometer hasn't been manufactured for the last 40 years. Why? We all face that. And it's that collaborative communication effort that will really help. I'll also tell you that it's a big waste, but RTLS, if you put those on your thermometers, you'll see a huge heat spot right in the locker room. And that's because they like to own their own ones. You'll also find stuff in ceilings because they like to hide that stuff too. So RTLS is a great investment. Maybe too expensive to put on thermometers, but maybe not. So each organization is a little different with that, but it's all about that collaboration. It's about that partnership. It's about, you know, getting out, communicating, taking donuts to your infection control manager, director, so they fight those battles for you. And KISS. So I have a coworker. She changed it because she didn't like my keep it simple stupid. So she changed it to keep it simple smart. So we'll go with that. When you have a joint commission coming, DNV, CHIQ, CMS, don't reinvent the wheel. Do what you're always doing. If you stay prepared, you'll be prepared. There's many times I've been eating breakfast and they're like, joint commission's here. Okay, great. They're like, well, aren't you gonna go round it up? I'm like, no, I'm ready every day. So, you know, at the end of every month or the beginning of every month, you get your books together, you make sure your data is on point, you have your EOC meetings. There's nothing to run about and worry about or stress if you're always ready. Once again, don't change what you're doing. You guys know what you're doing. Obviously, it's situations and opportunities like this that allow you to collaborate, maybe come up with a new idea, think of it in a different way. That's when the changes happen, not when somebody's knocking on your door or about to show up. If anything, it's a perfect opportunity for you guys to reinforce what you're doing and making sure that they are following directions. They are communicating. They are, you know, ensuring that things are getting clean, cable management, you know, sticker residue. Is an opportunity to put it all together to see and test if your organization or your department has it together. Once they leave, by all means, it's a great opportunity to sit down, reevaluate what worked, what didn't work, what can we improve, what can we do? How can we work with our partners, whether it's third-party vendors or it's with our CMMS system to get that additional data point, make it easier. Whether we go to a digital platform where we can use smartphones or we can move away from paper, you'll always get the post-it note with broken, no matter how advanced we get, just FYI. And it's just broken. You don't know what the broken is, but it's broken. Now, if it's in 100 pieces, it's self-explanatory, but otherwise, you want to keep it simple, keep it smart, and it's the foundation of relatability. Once again, it's all about perception. So if you're out there, you're rounding, you're taking care of your customer, you're taking care of the equipment, you're doing a proactive approach. They don't see you just when there's a dumpster fire going on. It creates a overall environment to thrive in. Not only just for your medical equipment, but for your department, for your employees, and for your organization as a whole. Things will come up. They will, whether it's that thermometer from the 1950s or the mercury-filled thermometers that's still in the doctor's office that refuse to give it up. There'll always be something. But as long as you have many of these basic principles in place, it creates a much easier environment for you to keep your ducks in a row. Once you have your system in place, enforcing that, keeping a constant state of readiness will really allow you to be able to react, change, address, or potentially sit down and have hard conversations to move the needle to the next opportunity and maintain your organization's ready. Has anybody ever tried to herd ducks? I'm bringing this back to the fact that I grew up in the middle of nowhere, had ducks. Ducks are fine, stay away from geese. Very dangerous, never happy. I don't know what that is, but I know we went through that relatively quickly. I know we're bumping up against lunch, so that was on purpose. So what questions do we have? Yes, sir.